So when and how does one identify a dissociative disorder? Well, there are various approaches and also several tools and resources available. However, most of them are appropriate for either therapists or for patients with dissociative disorders, not for both. This is a notable exception. The Dissociative Identity Disorder Sourcebook, published by Deborah Haddock in 2001, is written in very accessible language by a credible therapist in a way that is appropriate for patients, therapists, and also for individuals working or living with those suffering from dissociative disorders. Although some of the information may be slightly dated, this book offers excellent real-life illustrations and practical advice. As such, it is extremely helpful for raising awareness, promoting insight, facilitating the removal of amnestic barriers, and destigmatizing the condition. The following several slides on how to recognize and diagnose dissociative disorders is based on a condensed version of this material from the book. The goal is to present a clearer picture of how individuals with DID may actually be recognized in relational, work, or in therapeutic settings. The objective is to increase awareness and also to assist in navigating the process of considering, confirming, and managing dissociative disorders. As explained previously, the sequential building blocks for making the diagnosis of a dissociative disorder include the following: obtaining a thorough history, which may not always be possible at first; then direct observation, specific screening for dissociation, consideration of differential diagnoses and ruling out other disorders, and finally, confirming the diagnosis. This process of assessment and diagnosis of DID might sometimes be completed within a few sessions, or it may extend well into the first stage of treatment. The dissociative features may be especially difficult to diagnose initially because clients tend to enter therapy or medical systems in a state of crisis. Therefore, immediate stabilization and safety get the greatest emphasis, as indeed they should, but with the implication that the process of achieving a definitive diagnosis is delayed by practical necessity. There are several features that raise the probability of an underlying dissociative disorder. To start with, though, DID patients almost by definition are creative and intelligent individuals. Without this, they would not have had the mental resources to develop this level of mental fragmentation to survive. When experiences or emotions became too overwhelming in early life, their minds were able to encapsulate this and store it for safekeeping. The fragmentation or detachment from their consciousness was a survival mechanism, not a weakness. It was the price they paid to survive at the expense of being a fully integrated person, if such a state actually exists. Although many people block out memories in the face of trauma, DID individuals encapsulate these experiences as distinct ego states. In the jargon of the field, these individuals are then made up of a so-called ANP, or apparently normal person, who is usually but not always the predominant identity and functioning part, and any number of other EPs, or emotional parts. Then in later years, these individuals may respond to difficult circumstances by entering into any one of the EP mental states, each of which may manifest features of a distinct psychiatric disorder. As such, a DID individual may have certain mental disorders when operating in one EP state, which is then absent or exchanged for another when in another EP state. These disorders may include generalized anxiety, shutting down, suicide, depression, using alcohol, and binging or purging. This is also why pharmaceutical treatment is often unhelpful for DID, because what works for one part fails to help another or may even exacerbate the condition. It is common for dissociators to have a lifelong history of certain physical symptoms. The latter are often but not always medically inexplicable and highly variable. Some medical tests have even shown different results based on the presenting personality. The nature of the physical symptoms may include non-specific stomach problems, headaches that are often diagnosed as migraines, urinary tract problems, aversion to certain foods, or even a strong gag reflex that may be an indicator of oral sexual abuse, choking, or other types of physical assault as children. Although such physical symptoms are not part of the diagnostic criteria for DID as such, they are important clues that should not be missed. Unfortunately, they often are, and DID patients tend to accumulate diagnoses, typically an average of 7 before anyone picks up on the dissociative aspects of their behavior. By the time you get to consider the diagnosis, most DID patients will have or will have had several therapists, a variable number of medical tests with ambiguous results, and still no satisfactory resolution of the problem. Still, even if suspected, confirming the diagnosis of DID is not necessarily easy. It is often hidden in plain sight. The dissociative personality system is specifically configured to deliberately avoid detection, the key is being able to look beyond the immediate crisis that precipitated the need for medical care. People with dissociative disorders rarely go into therapy for the dissociation itself. Rather, it's the failure to cope with an unusually stressful situation, emotional leakage from the EPs in the form of depression or anxiety, or just because their life feels out of control. A detailed history will often reveal an ongoing lifestyle of chaos. The same phenomenon is likely to be experienced during therapy in the form of missed appointments, sudden mood changes, and forgetfulness. So, just to re-emphasize this then, if an individual has seen several different therapists over time for a range of mental and non-specific physical disorders without reporting significant improvement, it is appropriate to also screen for dissociation. The most obvious way of diagnosing dissociative disorders is actually witnessing the dissociation. But this may not be so obvious in the early stages of getting to know someone in a brief intermittent therapeutic relationship. As the therapeutic relationship strengthens, though, it is important to retrieve more detailed information about the individual's upbringing, social, psychiatric, and medical history, as well as the family dynamics and any direct or indirect history of abuse within the family. Even though the full nature of the abuse may not be immediately forthcoming, the client may nevertheless describe relationships and behaviors within the family that point towards abuse, neglect, and disorganized attachments. A big part of the relevant family history also involves determining how rules and consequences were enforced within the period of growing up, and how family conflicts were resolved. Alcoholism and addictions will often become evident then, and it may start to offer insights on how the family system worked. Beliefs about conflict and affection need to be understood, as well as nurturing and forming healthy attachments to a caregiver, especially if this did not occur consistently within their own families. A thorough history is more likely to provide insight on the direction to proceed. Generally, confronting issues directly will have to wait until the relationship is sufficiently strong and enough stabilization has been achieved. Note that, although it is perfectly appropriate for therapists to ask people about childhood abuse and to describe their past experiences as being abusive, even when the client does not seem to agree, it is nevertheless inappropriate for therapists to insist that an individual was abused when they believe they were not, even if this belief appears to be a form of denial or due to dissociation rather than representing reality. It is also inappropriate for therapists to recommend hypnosis or drugs solely for the purpose of uncovering repressed memories. There are many reasons for screening individuals for dissociation. Dissociative disorders should be considered in anyone who is polysymptomatic with several mental disorders or psychiatric diagnoses. Regular bouts of unexplained headaches, visual disturbances, stomach aches, irritable bowel syndrome, urinary tract disorders, and nausea should prompt consideration. Again, although these physical symptoms are not specific for dissociative disorders, nor do they form part of the diagnostic criteria, they are consistent with the way in which both animals and humans react to trauma. These somatizations or somatoform dissociations often represent flashbacks, sometimes also called body memories, or they may be part of the dissociation and switching. Intermittent, severe headaches are especially indicative of switching or internal conflicts amongst parts. Another important indicator is periods of memory loss. The memory loss is not only for parts of the individual's childhood, but it may also present as current periods of memory loss, so-called dissociative amnesia. These may be reported as blackout spells and can lead to many blind alleys of extensive medical investigations for neurological or cardiac problems, which are often normal or inconclusive. DID clients may also make statements like, "I have a really bad memory," or "I don't remember much before the age of whatever." Additional issues that might suggest a diagnosis of DID include reports of inner voices, different from those reported in schizophrenia. There may also be what I have come to call crisis clusters of issues that are suddenly brought to the fore, such as repetitive nightmares that originated in childhood, panic attacks, self-injury, and hidden behaviors such as eating disorders and chemical dependency. Substance abuse is often used to numb the host, or the ANP, which may also assist in keeping the personality system secret and pushing memories into the subconscious while focusing time and attention on the addiction instead. Suspicions of personality switching may be raised by differences in handwriting, distinct voice changes, variations in appearance and the style of dress or the way clients present from session to session. According to Colin Ross, the typical DID client is female, aged 20 to 40, with a history of early childhood abuse. She will report blank spells, voices in her head, or other symptoms more commonly associated with schizophrenia. The DSM criteria would be met or nearly met for borderline personality disorder. She will have had unsuccessful treatments, reports of self-destructive behaviors, and chronic headaches, but without the presence of a thought disorder. Using the Dissociative Experience Scale, or DES, and the Somatoform Dissociation Questionnaire, or SDQ-20, one may be able to screen more carefully and determine the degree and the function of the dissociation at this point. It is important to differentiate dissociative disorders from schizophrenia. Generally, dissociators will score on some of the positive symptoms of schizophrenia. Colin Ross refers to this as the so-called multiplicity triad. These may include believing that thoughts, feelings, or actions are being controlled by something outside. They may also include beliefs that others can hear their thoughts, or that their thoughts are being taken out of their mind, or that there are voices commenting on their actions. Other components of the triad include hearing internal voices and reports of past suicide attempts. But a major distinguishing factor between DID and schizophrenia is that dissociators hear voices from within themselves, and they don't lose touch with reality, as is the case with psychosis. Many dissociators report that they have lived with internal voices for as long as they can remember, and they are often surprised that others do not. They may therefore consider these voices as just being a part of themselves. Additional helpful information includes a thorough physical and medical history. Apart from schizophrenia, though, the other most prevalent diagnostic issue is borderline personality disorder, or BPD. It's quite common for dissociators to receive this diagnosis at some point in the course of their therapy. And BPD is characterized by desperate efforts to avoid real or imagined abandonment, unstable relationships, a tendency to consider people either as all good or bad, impulsiveness that is often related to substance use or sexual behavior, recurrent suicide attempts or self-mutilation, and inappropriate displays of anger. Persons with DID may look very similar as they switch amongst ego states. However, BPD should not be a wastebasket diagnosis for clients who have difficult behaviors and symptoms. It may be appropriate, however, to diagnose both DID and BPD in the same individual if they truly have features of both. There remains significant controversy about the classification of BPD and DID, but the loss of memory associated with DID is not a feature of BPD. Also, mood changes in BPD do not constitute a change in personality to the extent that a part of the mind takes control of the body outside of the individual's consciousness. The classification of BPD as a personality disorder has unfortunately led therapists and funders to consider that these individuals will never change. Often, however, the dissociative aspects have never been addressed, which is crucial to successful treatment of dissociative disorders. As such, the International Society for the Study of Dissociation, the ISSD, has developed general guidelines for the diagnosis and treatment of DID. It states that the foundation for diagnosis is a mental exam that focuses on questions related to the dissociative symptoms. The ISSD also recommends the use of the dissociative screening instruments such as the DES or Dissociative Experience Scale, and specific instruments such as Colin Ross's Dissociative Disorders Interview Schedule, the so-called DDIS, and Marlene Steinberg's revised Structured Clinical Interview for DSM Dissociative Disorders, the so-called SCID-DR. The SCID-DR identifies 5 core dissociative symptoms that must be present to diagnose a client with DID or dissociative disorders not otherwise specified. These symptoms are 1. Dissociative amnesia, 2. Depersonalization, 3. Derealization, 4. Identity confusion, and 5. Identity alteration. DID, as it is experienced by the dissociators, is identity confusion, whereas non-dissociators typically experience life in a more integrated manner. This experience is aggravated when the dissociator feels disconnected from the world around them, as if living in a dream at times. In order to now provide an update on Deborah Haddock's material, I need to briefly point out the changes in the criteria for the diagnosis of dissociative disorders, as they have several important practical implications. With the introduction of DSM-5, greater emphasis has now been placed on differentiating the nature of the dissociation response more precisely. In other words, although there are other diagnoses that have features of dissociation, such as PTSD, the specific features of derealization, that is a form of detachment from the environment, depersonalization, which is a detachment from themselves, identity confusion, and amnesia are what set dissociative disorders in a separate category. Derealization is now included both in the name and symptom structure of what was previously called depersonalization disorder. It is now called both depersonalization and derealization disorder. Secondly, dissociative fugue is now a specifier, that is, an additional descriptive element of dissociative amnesia rather than being a separate diagnosis. And thirdly, the specific diagnostic criteria for dissociative identity disorder have been expanded in the following way. The so-called criteria A for DID, which address the identity alteration specifically, has been expanded to include certain possession form phenomena and functional neurological symptoms to account for more culturally diverse presentations of the disorder. Criteria A now also states specifically that transition in identity may also be reported by other observers as well as the individual themselves. Criterion B, which addresses the amnesia, has been extended to include current and recurrent gaps in recall for everyday events, not only for the original traumatic experience. Other text modifications clarify the nature and time course for identity disruptions. So what is actually known about the cause of dissociative disorders, and what effect does it have on the individual and on society? Based on extensive international research over more than 3 decades, there is now compelling evidence that dissociative disorders, and dissociative identity disorder in particular, occurs in response to extreme childhood relational trauma. Specifically, they develop when a child is exposed to chaos, coercion, and most commonly overt, severe physical and/or sexual abuse, often with disorganized attachment to caregivers. They also need the biological capacity to dissociate to such an extreme level, which then leads to multiple states that do not become integrated over time. There's an ability to compartmentalize the overwhelming and conflicting feelings of betrayal, terror, love, and shame. There are two primary contexts associated with the trauma: sociocultural and organizational. They frequently merge. The sociocultural version is most related to domestic violence, rape, incest, or long-term opportunistic abuse. The organizational version, also called ritual abuse and mind control, can include religious, cultic, or even military intelligence varieties, which also may merge and overlap. The various methods used to deliberately traumatize and exert mind control over victims' minds falls outside the scope and purpose of this presentation. Often the descriptions go well beyond the range of most people's wildest imagination. For various reasons, the validity of these memories are the subject of much controversy. Given the far-reaching implications, there has been significant pushback in the form of allegations of trauma survivors having false memories, or that many memories are fabrications, or that they are anomalous responses of highly suggestible creative individuals to the psychotherapeutic process itself. The impetus behind these criticisms has actually spawned an organization dedicated to the sole objective. However, whilst survivor stories may not always be accurate and the details may seem bizarre, there are many credible and scientific resources that have carefully documented the validity and scope of ritual abuse and military-motivated mind control, as well as the effects of these on survivors. The collective evidence goes far beyond the realms of conspiracy theories or myths, and therapists are cautioned against making assumptions. What is even more surprising, though, is that recovery is possible for these survivors, and it is, but therapy is lengthy and the costs are high for everyone involved. Part of the difficulty in understanding these disorders and developing evidence-based therapies is that research is so challenging. This is not only because the severe childhood relational trauma may implicate organizations and families, but also because the DID individuals themselves are conditioned not to tell. This conditioning is strengthened by self-denial, shame, threats, either from perpetrators or even alter personalities within themselves, and the response of disbelief from those who they dared to entrust with the information in the past. As such, there are many barriers to researching this disorder, which is one of the reasons why it has remained so poorly understood and controversial until recently. The abuse of adult power over children calls families, social organizations, and carers into question. It is emotionally and politically complex and taxing to those who intervene or provide care and safety on behalf of the victims. All of these facets form a powerful disincentive towards providing care or conducting research on these conditions. Having said that, to ignore the problem protects perpetrating individuals and institutions at the expense of their victims, and it perpetuates the problem by facilitating comforting denial of the abuse and its impact on the victims and on society. Just before we look at the various therapies employed in managing dissociative disorders, I want to remind you briefly of possibly one of the largest and perhaps less visible contextual challenges. During the first part of this lecture series, we reviewed the various concepts in the mutation of a sense of self: insanity or derangement of the mind, somnambulism or intrusion or psychic attachment, and hysteria or imagination or detachment. We also mentioned that dissociative disorders in particular display features that could be assigned to each, any, and even all of these categories. There is a definite developmental biological derangement of the self. There are certain features resembling psychic or psychospiritual attachment and the internalization of external psychospiritual influences, but there also seems to be an adaptive compartmentalization or detachment of the psyche with the formation of distinct internal psychic constructs. As a result, depending on the biopsychosocial-spiritual environment in which people develop DID, as well as the worldview of those providing or being willing to provide help, there has been significant diversity in both the expression and attribution of cause of these disorders. Generally speaking, in Western cultures, dissociative disorders are attributed to fragmentation of the mind, detachment from reality, an adaptive, reactive, or even deliberately directed reorganization of the psyche. In non-Western cultures, though, the association with external psychospiritual forces, entities, or attachments is far stronger. Not surprisingly, given the blurring of social boundaries in modern and postmodern society, it is not unusual for the predominant biopsychosocio-spiritual views of the community, those of the affected individual, and those of the therapist to be at odds with each other. So a significant part of the challenge in classifying and managing these conditions has been to accommodate these divergent views within a diagnostic and therapeutic framework that is safe, stable, suitable, sustainable, and socioculturally neutral enough to allow clients and therapists to engage and collaborate. This is not an overstatement. The diverse perspectives on cause and effect can produce tremendous confusion, vulnerability, and social alienation. Add to this the secretive and bizarre context in which the childhood relational abuse may have taken place, and the clinical setting becomes a potential socio-political religious minefield. To its credit, then, the current DSM-5 has attempted to capture some of these intercultural variabilities in its criteria, but at the expense of greater specificity. The implication of combining possession and fragmentation phenomena into the same clinical category is not trivial. The need for, or the relevance of, making any causal distinctions based on external features now largely disappears. So, irrespective of whether the individual expression of the condition seems to favor some form of attachment or detachment of the mind, both are now accommodated within the same clinical category, with any diversity being attributed to the sociocultural context. Ultimately, whether or not this was the appropriate decision, only time will tell. What it has achieved, however, is greater awareness, arguably less stigmatization and perhaps misdiagnosis, and more uniformity in a foundational therapeutic approach.